If you work in a hospital setting, elective cardioversion for atrial fibrillation is just another Tuesday. It is a highly routine, everyday clinical procedure. But before you deliver that synchronized shock, you have to make a choice that often causes unnecessary friction in the room. Where exactly do you place the defibrillator pads? This illustration shows your two standard options, the anterolateral, or AL configuration on the top, and the anteroposterior, or AP setup on the bottom. For decades, medical training has treated that AP position on the bottom as the gold standard. The physiological logic seems sound. By placing one pad on the front of the chest and one on the back, you sandwich the heart, theoretically driving the energy straight through the left atrium to restore a normal rhythm. But choosing that AP setup requires physical labor. It means rolling a sedated patient onto their side, often grabbing a razor to shave their back for pad adhesion, and then wrestling them back into a flat position. We go through this process on almost every shift because we assume it yields better results. But it is worth asking if that theoretical sandwiching effect actually justifies the physical setup friction it demands. To answer that, we have to look at the equipment we're actually using. Today, almost every clinical setting relies on modern biphasic defibrillators. These are entirely different from the older monophasic machines that dominated emergency medicine back when the AP pad dogma was first written into the textbooks. Monophasic machines fired a single electrical current in one direction. Biphasic machines, however, send current back and forth across the myocardium in fractions of a second. The issue is the foundational studies supporting the AP position were entirely based on outdated monophasic machines. We are applying 1990s data to 2020s technology, creating a mismatch between physiological theory and modern clinical reality. So if the physics of the electrical shock have evolved, we have to find out if the AP position still actually guarantees superior clinical outcomes. Relying on old data traps us into outdated protocols, forcing clinical teams to perform unnecessary steps at the bedside for a benefit that might not exist anymore. That brings us to the 2021 ADDIC trial. This was a multi-center, randomized study that finally put AL and AP head-to-head using modern biphasic defibrillators. This chart plots patients achieving sinus rhythm based on number of shocks. For first shock success, AL achieved 54%, compared to 33% for AP. That's a 22 percentage point gap out of the gate favoring front and side placement. For clinicians, this means you're far less likely to need multiple shocks at escalating energy. Even looking at cumulative success after 4 shocks, the AL group leads with a 93% conversion rate versus 85% for AP. AL placement restores sinus rhythm more reliably, while requiring fewer total shocks to get there. The empirical data proves that the theoretical sandwiching benefit of AP is a myth in the modern biphasic era. Let's translate those numbers into the physical workflow of preparing a patient. To use the historically preferred AP position, your team has to physically roll a sedated or pre-sedated patient to get access to their back. You also frequently have to shave the skin back there to ensure the pad actually sticks properly, adding steps to the setup. Contrast this intensive prep with AL placement. The patient stays flat on their back, and the team can attach both pads with minimal physical manipulation. If you're wondering about adverse events, the EPIC trial tracked complications. There was absolutely no difference in safety outcomes between the two groups. Patient-reported pain and skin redness were also completely comparable, regardless of where the pads were placed. Defaulting to AP placement means you are taking on unnecessary physical labor to achieve a statistically inferior chance of converting the rhythm. There is one specific scenario where the old AP dogma feels highly intuitive: treating obese patients, a very common demographic in atrial fibrillation cases. This EPIC trial forest plot breaks down clinical outcomes by patient subgroups. Look at the obesity classes. AL placement's advantage actually widened here, showing a massive 15 percentage point advantage for obese patients. This directly contradicts the clinical instinct that larger patients with more adipose tissue require an AP sandwich to effectively push energy to the heart. A failure on the first attempt necessitates immediate escalation to higher energy levels, increasing the total electrical load delivered to the patient. Prioritizing AL placement for larger patients serves as an evidence-backed strategy to maximize the success of that critical first attempt. Even in the cases where the historical logic feels the most convincing, the objective data proves AL is simply the superior choice. While the data strongly supports AL, major resuscitation guidelines like IL-Core and ANZ-Core still classify both pad positions as acceptable. That acceptable rating matters because AP placement still has a critical role to play when the AL position just isn't physically feasible. You will encounter patients where very large breast tissue or severe lateral chest hair prevents solid pad adhesion on the side of the chest, and you simply don't have access to a razor. There is also a specific mechanical barrier to consider: the presence of implanted medical devices, like pacemakers or defibrillators. You cannot discharge energy directly over an implanted device. In these cases, pivoting to the AP position is the safe, correct move. This is a calculated trade-off. You are accepting a slightly lower probability of first shock success to safely accommodate the unique anatomy in front of you. The choice of pad placement shouldn't be a rigid rule, but a flexible decision dictated entirely by the patient's physical presentation. We can use a modernized decision-making framework for elective AF cardioversion. The AL position should be the primary path, prioritizing maximum first shock success. The AP position becomes the alternative path, reserved for patients whose specific anatomical barriers require it. If you are a clinical educator or a QI leader, audit your departmental guidelines to ensure they actually align with this biphasic data. Unlearning decades of muscle memory takes conscious effort from the whole team at the bedside. The goal of evidence-based medicine is to reduce unnecessary friction while maximizing patient outcomes. Stop treating AP as the gold standard, and instead let empirical data, not an outdated tradition, drive your next procedure.